That's awesome. I think, that's where we use it too. So if we've looked at our data and kind of how often we've used the LAL plus versus the LAL, and it is about 50-50 in our practice. We do the LAL plus in those virgin corneas, the corneas that a cornea that you would put in a depth of focus or you would consider putting in a multifocal,
Exactly.
20/20 capable eyes. So that's how we use the LAL plus. Now, how do you guys determine eye dominance? Everybody's got a different test on how they do that. How do you do that?
Oh, that can get to be a big stickler. I mean,
Sure.
I think you can look and probably find pretty good studies because it's been come up as an issue throughout, eternity in refractive cataract surgery or LASIK or what have you.
Uh-huh.
I do the good old
Yeah.
2 feet center. We have this little logo, New Samai logo that we put at the end of all rooms, and I just have them center it. And I'm watching really carefully, make sure they do it correctly. That's what I do. That's what I do.
So that's also what I do in the consult as well. And then if push comes to shove, we are in Florida, Nick. A lot of people have guns.
Yeah.
Yeah, that's
Um,
the other thing.
so
The
I
same
was gonna,
patients that we have up in Wisconsin.
yes, yes. So and nothing, we're not gonna get political on this,
No, don't get political.
but but you always ask me, what's your shooting eye? And
Yeah,
everybody always
I do
knows
that
it down
too.
here.
I do
Yeah,
that
it's
too.
just a shorthand,
How do you
obviously.
line up a gun? Do you ever shot a gun?
Yeah.
Yeah,
I do
that's
that
my
for all
thing.
our patients too, and it's always funny when like I'll just say that kind of out of habit. First question. The study that you just talked about, your little in-house study, was it LAL in the dominant eye, LAL plus in the non-dominant, or was it LAL plus in both?
It was no, it was a mixing. So it was the all those patients were an LAL regular in their dominant eye for
Okay.
distance, and it was an LAL plus in the non-dominant eye.
Okay. Second question. How often does it come up where patients' eye dominance switches? Do you get that?
So yeah, actually, I had to throw 2 patients out of the study just because they switched the eye dominance.
Okay.
Okay. And with those 2 patients, though, the outcome OU was still 2015 J1, which is kind of hilarious how that happened. Which I mean, which is great for us. You know, what I mean, now is that due to the lens? Is that due to a little bit of depth of focus in the other eye as well? With the regular LAL. So that's that does happen because you do sometimes. Faz, you can comment more to this the dominant switch after cataract surgery. It does happen.
It does, because that's sometimes when you see that bad cataract in one eye and the patient just kind of shifts that dominance and you're doing the test and it's just wrong. They just don't see well. What are you going to do? The cool thing with the LEL, like, we always try to target, hyperopic and go in one direction. I know there's been some thoughts on that, but we've always been successful with that technique. We can dig deeper into that if you'd like, because there's been some changes of thought process, I think, a little bit. But when you do that, you can retest dominance when both eyes have the cataracts out and kind of try to drive it that way as well. One of the other comments I wanted to make is you guys are making great points, but I try to dumb it down. And for some of the ODs in the audience, anyways, the way I try to think of LAL plus and LAL is kind of like near-centered biofinity contact lens of low power.
Hmm.
So it's going to do well at near. It's not perfect at near, but it's not killing your distance. And to your point, Nick, the way that it achieves power is just kind of slow power change gradient to the center. It's very gentle, so it really preserves a lot of distance vision. But let's be honest, too, it's also an extended depth of focus lens, period. So there are going to be those patients when you have that selection process, which again we can drive into, that you got to be careful that if you put 2 of those in and you have not properly evaluated those patients' needs, you can get in trouble there. You can get in trouble with distance vision. Not often, we do a lot of bilateral pluses, to be honest. We again can dive into that, but I just want to kind of make that analogy for ODs that do kind of modified multifocal fits, where you do like a multifocal in one eye, but the
Hmm.
person's really picky at distance, so you put a regular monofocal in the other eye. That's kind of the way I try to explain it to other ODs so they're comfortable with it. It's very important to be comfortable with what you're doing, to be able to be that expert in the room and to talk to patients and get them comfortable.
That's a good point. I mean, so full disclosure too, we don't do a lot of mixing matching in Milwaukee because I've observed that and this is kind of the beauty of this platform is we can disagree and both be right. The
Right.
LAL and the LAL plus, I mean, the eye dominance does flip maybe 10% of the time. You know, you've got
Yeah.
patients who are they're ambidextrous. You know, they can throw with their left
Yep.
hand and their right hand. And sometimes they have no idea, you know, their right eye might be the better of the seeing eyes because their cataract in the left eye is worse, but it turns
Right.
out that their left eye is actually their dominant. And so I don't always love committing, although we have done it and have done very well with it. But that's the beauty of having the LAL and the LAL plus.